Hello again, I'm Dr. Greg Oliver, and today let's take a close look at the peptide hormone, insulin. If I had to name the single most important hormone when it comes to your body weight, your metabolic health, and your risk of chronic disease, it wouldn't be cortisol, it wouldn't be thyroid, it wouldn't even be the GLP-1 hormones we talked about so much in my last video. It would be insulin. Insulin sits at the absolute center of everything: weight gain, weight loss, type 2 diabetes, metabolic syndrome, cardiovascular risk, even your energy levels throughout the day. And the problem? Most people, and honestly, far too many doctors and clinicians don't really understand what insulin does, what happens when it goes wrong, and most importantly, what we can do about it. Today, we're going to look deeply at insulin. We're going to cover what insulin actually is, how it works in the body, what happens in type 1 and type 2 diabetes, what insulin resistance really means, and why it makes you gain weight, and what the most powerful tools in modern medicine, including diet, exercise, and our newest receptor-boosting medications, do to insulin balance. By the end of the video, you will understand your own metabolism better than most people who are walking the halls of the hospital. So let's get into it. Let's start at the beginning. What is insulin? Insulin is a peptide hormone. Peptides are made up of amino acids, the same building blocks as protein. A hormone is a messenger substance that moves from one cell or tissue type to another to give the second cell or tissue a signal or a message and tells it how to behave, adjust, create, or stop doing something. In the case of insulin, it is produced by specialized cells in your pancreas called beta cells, which are clustered on tiny islands of tissue called islets of Langerhans. You now know more than 99% of the population about insulin. I want you to think of insulin as the master key of your metabolism. Every cell of your body has insulin receptors. These are little locks on the cell surface. When insulin shows up and fits into that lock, the cell gets a very specific set of instructions. Now, insulin has 4 primary target tissues: liver, muscle, fat, and brain. Insulin's actions vary and produce multiple critical functions across every major tissue system. So let's look at what it does to these 4 tissues. In liver, insulin tells it to stop producing blood sugar. What most people call sugar is glucose. It tells them to store the glucose as glycogen and to convert any excess sugar to fat inside the liver. In skeletal muscle, it tells us to absorb glucose from the bloodstream, use it for energy, or store it in the muscle as glycogen. In fat tissue or adipose tissue, insulin tells it to take up glucose and fatty acids and to build fat stores and to block the breakdown of fat into fuel. And in the brain, insulin tells it to regulate our appetite, sense energy use by the body, and signal us when we are full and have eaten enough. As you see, the most fundamental job of insulin is to regulate our glucose. When you eat carbohydrates, your blood sugar rises. Your pancreatic beta cells sense this rise and release insulin into your bloodstream. Insulin then signals your liver and muscle to pull that glucose out of the bloodstream, either to burn it or to store it in our cells. But insulin is also a powerful anabolic hormone. That means it drives storage and building. It tells your body, hey, we have fuel. Let's store it or let's build with it. This anabolic or building effect is exactly why when insulin goes wrong, weight problems will follow. Now, I'd like to discuss what happens when insulin fails us. The result is type 1 and type 2 diabetes. Type 1 diabetes is a story of destruction. In type 1 diabetes, the immune system makes a catastrophic mistake. It identifies the insulin-producing beta cells of the pancreas as foreign, as an enemy, and it destroys them. This is autoimmune disease at its most consequential level. The result is absolute insulin deficiency. Patients with this disorder produce very little and most of the times no insulin at all. Without intervention, meaning giving them external insulin like shots, blood glucose levels rise to dangerously high levels. yet cells are starved of energy despite having plenty of glucose in the blood. My biochemistry professor in medical school called this starvation in the midst of plenty. When this happens, a life-threatening condition called diabetic ketoacidosis, or DKA, can develop. In DKA, the body, desperate for fuel, begins breaking down fat at an extreme rate. This produces acid compounds called ketones. When they accumulate faster than the body can process them, the blood becomes more acid, the pH drops, and this becomes a medical emergency. Type 1 diabetic patients require exogenous or external supplies of insulin for their entire life. This is not a lifestyle disease. This is an autoimmune destruction. And we can manage it beautifully now with modern technology like insulin pens, insulin pumps, continuous monitoring devices. So far, though, we cannot cure it. Let's move on to type 2 diabetes, which tells a completely different story and disease process. And this distinction matters enormously. In type 2 diabetes, the problem isn't that insulin can't be made. In fact, early in the disease, the pancreas is often making too much insulin. The problem is that the body's cells have stopped listening to the insulin. This is called insulin resistance. We're going to spend a lot of time on this in just a moment. Now, here's how type 2 diabetes develops over time. First, insulin resistance develops in the liver and the muscles. Next, pancreas beta cells compensate by producing more and more insulin. This is called hyperinsulinemia. Next, blood glucose is maintained, but at the cost of chronically elevated insulin levels. Then, beta cells become exhausted from persistent overproduction. And then, insulin secretion declines, blood glucose starts to rise. We develop prediabetes. This occurs, and then full-blown type 2 diabetes is diagnosed next. Listen, by the time someone is diagnosed with type 2 diabetes, they've often had insulin resistance and high blood insulin levels for a decade or more. The blood sugar was the last domino to fall, not the first one. This is a critical point, and it shapes everything about how we treat metabolic disease at my practice. We want to catch this process early before the beta cells burn out, before the glucose rises, and before the diagnosis of diabetes is even made, when much of the damage has already been done. Here's what insulin resistant actually means. Let me give you a real-world analogy for insulin resistance. Imagine insulin as a key and your cell a door with a lock. In a healthy, insulin-sensitive person, the key slides perfectly into the lock. The door opens instantly, and glucose flows in to give it fuel. Now imagine that the lock has been used so many times, so hard, for so long, that it's worn out, it's jammed. The key still fits, but you have to jam it in harder. You have to turn it more times. Eventually, you need multiple keys to get the door to open at all. And that is insulin resistance. Your cells still respond to insulin, but it takes more of it to get the same effect. So your pancreas produces more and more and more and more until it can't keep up. What causes this to happen? Well, the honest answer is a multiple factorial thing. But here are the primary causes. First, excess body fat, particularly visceral fat around the abdomen and organs. This fat releases inflammatory signals called adipokines and free fatty acids that directly impair insulin receptor signaling. The lock is being slowly damaged. Next, sedentary lifestyle. Our skeletal muscles are the body's primary site of glucose disposal, and without regular muscle contraction, this system becomes inefficient. Next, chronic inflammation. Long-standing low-grade inflammation interferes with the insulin signaling at the cellular and the molecular level. Also, sleep deprivation. Even a single night of poor sleep measurably impairs insulin sensitivity. Also, chronic stress and elevated cortisol directly opposes insulin's action, driving glucose up and promoting fat storage. Next, high calorie, high glycemic diets, high sugar diet, constantly feeding glucose, and insulin spikes over time, desensitizing these insulin receptors in the cell. And genetics also plays a role, as some individuals have inherited a predisposition toward insulin resistance. In the environment, the first 6 factors above, insulin resistance and diabetes are most likely to develop in these folks with a genetic predisposition. Notice something important on that list. Most of these factors are modifiable. That's not a guilt trip, it's an opportunity. And it's why the work of my practice is so powerful. Next, let's review what this insulin resistance does and its metabolic consequences. So, when your cells become insulin resistant, the downstream consequences work against every system in your body. The following metabolic changes will occur. First, insulin levels go up, or chronically elevated insulin levels. Next, dyslipidemia, or elevated triglycerides, and low HDL, which is our beneficial cholesterol, occur. Then hypertension, or high blood pressure, as insulin promotes salt and sodium retention and blood vessel tension. Then non-alcoholic fatty liver disease, which is due to excess insulin being converted to fat in the liver. For some women, polycystic ovarian syndrome, or PCOS, as insulin increases androgen overproduction in the ovaries. Also, accelerated cardiovascular disease due to the inflammation of the artery walls from excess insulin can occur. There's an increased cancer risk because insulin is a growth factor that can promote abnormal cell growth. Then there's central obesity, with fat being primarily deposited in the abdomen. Cognitive decline can also occur because the brain becomes less responsive to insulin signaling. This has also become known as type 3 diabetes, or a type of late onset Alzheimer's disease. This whole cluster of problems, elevated glucose, elevated triglycerides, low HDL, high blood pressure, central obesity, it has a name, metabolic syndrome, and it affects roughly 1 out of every 3 American adults. Insulin resistance isn't just a diabetes story. It's the foundational pathology behind most of the chronic diseases that kill people in the developed world. A question I often get is, why does excess insulin make you fat? Here's where things get pretty interesting and where most conventional diet advice fails people. Chronically elevated insulin doesn't just reflect metabolic dysfunction, it causes weight gain through several direct mechanisms, and I'm going to give you those. First, insulin powerfully blocks the breakdown of stored fat. As long as insulin is elevated, your body cannot effectively access its fat stores for fuel. You are biologically blocked from burning fat. Next, insulin promotes fat production. It causes the creation of new fat from excess glucose and carbohydrates, particularly in the liver and fat tissue. Then, insulin acts on the brain to drive our hunger and food-seeking behavior, particularly cravings for high carbohydrate foods. And elevated insulin drives sodium and water retention, which increases our weight from water. Chronically high insulin then shuts off a hormone called leptin sensitivity, which is the hormone that signals fullness, creating a state where your brain never gets the "I'm full" signal properly. So think about what this means in a practical setting. You're eating, your blood sugar spikes, your insulin spikes, your body is told everything it can. Your fat stores are locked up. You feel temporarily satisfied, but then insulin drives your blood sugar down and now you're hungry again. This is the insulin obesity cycle, and it explains why willpower alone is not a weight loss strategy. You are fighting your own physiology. This also explains something I see in my practice constantly. Patients who are eating a reasonable number of calories but cannot lose weight. When I measure their fasting insulin levels, it's through the roof. Their body is simply not in a metabolic state that will permit fat burning. One of the most underutilized laboratory tests in medicine is to check the fasting insulin level. Most physicians will measure your fasting blood sugar. They'll measure your hemoglobin A1C, which tells us a 3-month blood sugar average. And maybe they even check your lipid panel. But fasting insulin? It's rarely ordered, despite telling us more about your metabolic health than almost any other single test number. What should your fasting insulin level be? Well, less than a number of 5 is optimal insulin sensitivity and excellent metabolic health. Between 5 and 10 is normal and acceptable. 10 to 15 is early insulin resistance, and this is when we need to intervene. 15 to 20 is significant insulin resistance, and more comprehensive evaluation is needed. Greater than 20 is severe hyperinsulinemia and indicates high risk for metabolic disease progression. And if that number is greater than 25, you've got some disease, probably PCOS, fatty liver disease, metabolic syndrome, and a high risk for type 2 diabetes. Here's why this matters so much. Your blood sugar to glucose ratio can be completely normal while your insulin is highly elevated because your pancreas is compensating. You pass your blood sugar test, your hemoglobin A1C test looks fine, but your body is working overtime to maintain that glucose level, and the insulin-driven damage is already occurring. Fasting insulin allows us to catch this a decade before glucose rises. It gives us a window to intervene while the system is still correctable. We also use another calculation from those labs called HOMA-IR, H-O-M-A-I-R. This is the homeostatic model assessment of insulin resistance, which uses both fasting glucose and insulin together to give us a quantified resistance score. This is one of the most useful tools in all of metabolic medicine. The HOMA-IR formula is fasting insulin times fasting glucose divided by 405. Optimal is less than 1. Borderline is 1 to 1.9. Insulin resistance is greater than 2. Significantly resistant insulin is greater than 2.9. These are the numbers that should be tracked over time. When I have a patient whose HOMA-IR drops from 3.5 to 1.2 over 6 months of treatment, that is a major metabolic restoration, regardless of what their scale says. It's time to look at how our food choices directly drive our insulin levels. Of all the ways we have to modify our insulin levels, diet is the most immediate and the most powerful. I'd like to review how different dietary approaches affect our insulin physiology. So, a low carbohydrate ketogenic diet, it dramatically reduces insulin secretion and it promotes fat burning. It rapidly improves insulin sensitivity and lowers fasting insulin levels. Another diet called the low glycemic index diet reduces insulin spikes and gives moderate improvement in fasting insulin, and it is a diet that's sustainable long term. Intermittent fasting creates prolonged, low insulin periods and allows stored fat breakdown to occur and reduces insulin resistance over time. You've heard of time-restricted eating. It's similar to intermittent fasting. It also causes low insulin levels to promote fat burning and improves insulin resistance if you can adhere to that type of a diet. The Mediterranean diet also shows modest improvements in insulin sensitivity. It is anti-inflammatory and it provides a good long-term metabolic profile. However, an ultra-processed, high-sugar diet causes chronically elevated insulin and accelerates insulin resistance and promotes hyperinsulinemia. This is a common diet in America. High-protein diets will show moderate insulin response with a high satiety or feeling of fullness level. It preserves muscle mass and supports metabolic rate. The single most powerful dietary intervention to lower insulin levels is to reduce total carbohydrates because sugars and carbohydrates are the primary drivers of insulin secretion. Less carbs mean less glucose, which means less insulin. Less insulin, more fat burning. Now, this doesn't mean that everybody needs to be on a diet that puts them in ketosis. But for people with significant insulin resistance and high insulin levels, reducing refined carbohydrates and ultra-processed foods is a non-negotiable thing. So let me tell you what exercise does for insulin and its sensitivity. If diet is the most powerful tool for insulin, exercise is the most powerful non-drug tool overall. So here's what happens physiologically when you exercise. Skeletal muscle contraction activates glucose uptake through what's called an insulin-dependent pathway called GLUT4, G-U-L-T4, translocation. In plain language, it means your muscles can pull blood sugar out of the bloodstream without waiting for insulin's permission. Now, this is significant because exercise bypasses the broken lock entirely and opens a door through a completely different mechanism. Here are exercise effects on insulin use. Resistance training increases muscle mass, which permanently increases glucose usage capacity and is the most long-term and powerful insulin sensitizer. Next, aerobic exercise immediately depletes muscle glycogen, which improves insulin sensitivity for 24 to 48 hours after you exercise. HIIT training, high interval intensity training, is particularly effective at improving insulin sensitivity, and it activates certain pathways which actually improve cellular energy production and fuel utilization. Also, daily movement, the non-exercise activity you do, such as walking after meals, that will significantly blunt post-eating insulin spikes. Also, combined training with resistance and aerobic activity give the greatest overall improvement in HOMA-IR scores and fasting insulin levels. The research is unambiguous. Regular exercise, particularly resistance training combined with aerobic activity, is one of the most effective ways to reduce insulin resistance that exists. And it's absolutely free. For our patients, we typically recommend getting to a point where you exercise 150 minutes of moderate aerobic activity weekly, combined with 2 to 3 sessions of resistance training. That combination produces the most meaningful improvements in insulin sensitivity over time and will add healthy years to your life. Now, if you watched my Factor 3 video on metabolic enhancement effects of GLP-1 medications, then you're familiar with their activity. So I want to get into how these medications interact with our insulin physiology. GLP-1, or glucagon-like peptide 1, is a naturally occurring hormone produced inside your gut in response to eating. Its primary role is to signal the pancreas to produce insulin, but only when blood sugar is elevated. This is called glucose-dependent insulin secretion, and it's critically important because unlike some older diabetes medications, GLP-1 meds cannot cause low blood sugar on their own. They only stimulate insulin when glucose is actually high. Here are some key points to note about this. GLP-1s like Semaglutide promote appropriate post-meal insulin release. Also, it suppresses glucagon, which prevents the liver from unnecessary release of stored glucose. It also slows stomach emptying, which blunts the post-eating glucose spike that triggers insulin surges. It reduces appetite to decrease calorie intake, which lowers overall insulin demand. Semaglutide also promotes beta cell preservation in the pancreas and promotes remaining beta cell function in type 2 diabetes. It improves insulin sensitivity and weight loss, and the GLP-1s directly improve insulin sensitivity. So, how about the GLP-1/GIP dual agents like Tirzepatide? Well, they enhance glucose-dependent insulin stimulation through 2 different pathways. They also suppress glucagon production plus improve fat tissue insulin sensitivity. They delay stomach emptying. They can produce up to a 22% body weight loss. They are superior for insulin sensitization, especially in fat tissue via this GIP receptor. And they also show emerging cardiovascular improvement to date. So, these medications, semaglutide, tirzepatide, are transformative tools for patients with elevated insulin levels, significant insulin resistance, and obesity. Not because they are magic, but because they balance the underlying glucose to insulin dysfunction and can restore more normalized metabolic function. Thus, why I call it metabolic enhancement. I've spent this entire video talking about insulin resistance and everything that can go wrong. Now I want to flip the coin over and talk about insulin sensitivity. Insulin sensitivity is the goal, it's the target, and it is achievable. An insulin-sensitive individual is someone whose cells respond aggressively and efficiently to insulin. They need very little insulin to accomplish a great deal. Their pancreas isn't working overtime. Their fasting insulin is low. Their HOMA-IR is optimal. Their body can access fat stores readily between meals. And here are the defined goals we're looking for. We want a fasting insulin level between 5 and 8, a HOMA-IR less than 1, stable energy levels all day with no crashes, natural use of fat as fuel between meals, normal triglyceride levels and lipid profiles, and easier weight management with predictable body response to calorie adjustment. We also want reduced hunger and natural appetite regulation. We want lower systemic inflammation markers. We want to reduce the risk of cardiovascular disease, type 2 diabetes, fatty liver disease, and PCOS. And this is not some idealized fantasy. This is a physiologically normal state that the human body is fully capable of if you put the right inputs in. The pathway to insulin sensitivity runs directly through the interventions that I've been discussing: dietary carbohydrate reduction, regular physical exercise, adequate sleep, stress management, and when clinically appropriate, targeted pharmacological and medicine support. This is how I approach our patients in our office, and if you're not getting this complete approach to your weight, your health, and your energy needs, you need to look around for better care. So let me bring this all home now. Insulin is not your enemy. It's a brilliant ancient hormone doing exactly what it was designed to do. The problem is the environment we've built around it. The ultra-high processed food, the sedentary culture, the chronic stress, these things abuse the insulin system until it just breaks down. The good news is that the system is remarkably resilient, and I have seen patients with fasting insulin levels over 30, deep in metabolic disease territory, who within 6 months of comprehensive treatment had their numbers at near optimal levels. Their energy returned, their weight moved down nicely, and their inflammatory markers became normal. Now, this requires understanding what's actually happening in the body, which is exactly what my video series is about. Now, if you want to get serious about your metabolic health, your weight issues, your low energy level, get the proper testing and care. Get your fasting insulin checked and your HOMA-IR calculated. Understand where your metabolic health truly stands and build a plan that addresses the root physiology and the causes of this problem. If you find my content valuable, share it, because there are millions of people who have been told they just need to eat less and move more without anyone ever explaining to them the insulin story. But those are the people who need to see this the most. I'm Dr. Greg Oliver with Fast Clinical Weight Loss and Body Renew in Avon, Indiana. Our website is fastclinicalweightloss.com if you want to see what we do. Feel free to comment on my videos. I do read them all. If you have specific questions about weight, metabolic health, or my 5-factor program, feel free to reach out. I look forward to seeing you in my next video. So long for now.